The wound is already 3 days old. It has gone warm to the touch and the edges have started to pull apart the way a seam opens under pressure. The surgeon reaches into a clay bowl and presses a wad of gray-green bread against the flesh. Not fresh bread. Bread that has been sitting in a damp corner long enough to grow a coat of mold you can see with the naked eye. He holds it there. And here is the thing that should stop you cold. This is not ignorance. This man has done this before. He has watched what happens next. That is the paradox sitting at the center of ancient wound care. Rotting material pressed into open flesh sounds like a guarantee of death. Every instinct in your body says the same thing. Get it away from the cut. Keep the wound clean. And yet surgeons across cultures, separated by centuries and oceans, kept reaching for the same decaying substances, kept packing them into wounds, and kept recording cases where the patient lived. That pattern doesn't belong to superstition. It belongs to observation. The question is what they were actually seeing. Step into the world before germ theory. That world does not end in 1800. It ends in the 1860s when Pasteur and Lister forced the debate into the open. Before that, for the entire stretch of recorded medicine, from Egyptian papyri to medieval hospital records to Renaissance surgical manuals, healers had no word for bacteria. They had no concept of infection at the cellular level. What they had was their eyes, their noses, the pressure of a fingertip against swollen tissue. They could see a wound redden and smell it turn. They could watch a man spike a fever by the second day and be dead by the fifth. And they could see, some of the time, with certain substances packed into the wound, that neither of those things happened. The Edwin Smith Papyrus, written around 1600 BCE but copying surgical knowledge that is almost certainly older, describes wound management with a precision that reads less like ritual and more like protocol. Honey appears repeatedly, not as a comfort, as a packing material applied directly to open tissue. The Egyptians weren't guessing. Honey is hygroscopic, meaning it pulls water out of the wound environment, and most bacteria cannot survive without it. Honey also produces hydrogen peroxide slowly, in concentrations low enough not to destroy tissue but high enough to kill a range of pathogens. The Egyptians didn't know any of that in those terms. They knew that wounds treated with honey stayed cleaner. That was enough. Beside honey on the ancient healer's table sat wine and vinegar, both used across Greek, Roman, and Arab medical traditions. Wine contains alcohol and organic acids. Vinegar is acetic acid, both hostile to microbial growth. Again, the mechanism was invisible. The result was not. Hippocratic texts from the 5th century BCE recommend wine to clean wounds before dressing. Galen, working in Rome in the 2nd century CE, packs wounds with materials soaked in wine. The logic was not chemical. The logic was that wine-treated wounds tended not to kill the patient as quickly. Centuries later, Arabic physicians like Avicenna would codify similar observations into his Canon of Medicine, written around 1025 CE, treating wound care as a system built from patterns of outcome, not from any theory of what lived inside the flesh. Now, the bread. The moldy bread. This is where the historical record requires careful handling, because the story has been told sloppily in both directions. Some historians credit ancient Egyptians with deliberately cultivating mold as a medicine. The evidence for intentional mold cultivation in this period is thin. What the record does show is this: moldy bread and moldy grain appear as wound treatments in folk medicine traditions across Europe, the British Isles, and parts of Asia, documented in herbals, in surgical manuals, in the case notes of military surgeons treating battlefield wounds through the medieval and early modern period. John Parkinson's 1640 herbal references moldy material in wound treatment. Military surgeons in the Napoleonic era report observing that wounds exposed to certain molds seem to resist the worst putrefaction. These are not controlled trials. They are recorded observations made by people who had nothing to gain from lying and everything to lose from a dead patient. Set beside the bread, lint scraped from linen and packed into wounds to encourage drainage. Animal grease mixed with medicinal plants and applied as a seal. Poultices of various plants, some with demonstrable antimicrobial properties we can measure now, some entirely inert. The picture that emerges is not random cruelty. It is a practical system built around what healers could observe. Keep the wound from rotting, keep it from swelling shut with the wrong kind of fluid, keep the patient alive until the body does what the body does. And underneath all of it runs a question that none of these healers could ask in quite these terms. If the mold on the bread was doing something to the wound, something the clean bread could not do, something the wine alone could not do, then what exactly was it? What was living in that gray-green coat on the crust that a body under siege could use? That question sat unanswered for nearly 300 years after those Napoleonic surgeons made their notes. And then a man named Alexander Fleming answered it by accident. In September of 1928, Fleming returned to his laboratory at St. Mary's Hospital in London after a summer away and found a culture dish he'd left uncleaned. Staphylococcus bacteria, common, dangerous, the kind that turns a wound septic and kills slowly from the inside out. But contaminating the dish was a patch of mold, penicillium notatum, and around that mold was a ring of dead bacteria. A clear circle, nothing growing. Fleming didn't romanticize it. He simply noted what he saw. The mold was producing something that killed the bacteria around it. He published. The world did not immediately listen. It took another decade, and the pressure of a Second World War before Howard Florey and Ernst Chain converted that observation into a drug that could be manufactured and dosed. But the biological fact that Fleming documented in 1928 had been sitting inside every piece of moldy bread pressed into a battlefield wound for centuries. The mechanism was real. The people using it just couldn't see it. Here's what was happening in that gray-green crust. Certain penicillium molds, not all, not most, but some of the strains that colonize damp grain and bread under the right temperature conditions produce compounds that interfere with bacterial cell wall construction. A bacterium trying to replicate inside a wound treated with those molds cannot build the wall it needs. It ruptures. It stops spreading. The wound does not heal itself any faster, but it gains time. And time, in a world before intravenous fluids and surgical debridement and blood transfusions, was the entire margin between living and dying. But hold that margin clearly in your mind, because it was never reliable. The mold growing on bread in a Roman military camp or a medieval infirmary was not a standardized dose of anything. It was a biological accident of temperature, humidity, and the particular spores that happened to land on that loaf in that room on that day. Some strains of penicillium produce meaningful concentrations of antibacterial compounds. Some produce almost none. Some produce compounds actively toxic to human tissue. The healer reaching into that clay bowl had no way of knowing which version he held. The patient who survived wasn't necessarily saved by the mold. He might have survived despite it. The pattern of observation that led ancient practitioners to keep reaching for moldy material was real. The mechanism behind the pattern was real, but the distance between real mechanism and reliable treatment is exactly the distance that separates folk observation from medicine. The same gap runs through every other substance in that ancient kit. Honey worked, but honey also varies. Raw honey from certain floral sources carries higher concentrations of hydrogen peroxide precursors. Processed honey, diluted honey, old honey that has absorbed moisture from the air, all of these behave differently against a wound. Maggots, the larvae of certain blowflies, do something that surgeons still use. They eat necrotic tissue without touching the living tissue underneath, stripping the wound of the dead matter that bacteria thrive in. The Romans noted the effect. Medieval battlefield surgeons noted it. Modern wound care clinics use sterile maggot therapy for chronic ulcers resistant to other treatment. The mechanism is one of the cleanest in all of medicine, but a maggot left in a wound too long crosses a line. It runs out of dead tissue and starts on the living. The margin, again, was everything. Avicenna, writing in the Canon of Medicine around 1025 CE, understood something about this without being able to say it in these terms. He distinguished between wound treatments that produced clean healing and treatments that produced what he called corrupt flesh. He was categorizing outcomes he could observe without any theory of why those outcomes differed. That is empirical observation operating at its highest level under the available constraints. It is also the reason his canon remained a teaching text in European universities into the 17th century. He had organized what could be seen with the eyes into something that could be passed forward. What he could not do, what none of them could do, was separate the treatments that worked because of real mechanism from the treatments that worked by coincidence or that worked occasionally by accident in conditions that could not be reproduced. That separation only became possible after Pasteur demonstrated in the 1860s that microbial life caused putrefaction and disease. And after Lister applied that understanding to surgical antisepsis, suddenly the old substances could be interrogated. Honey, real mechanism. Keep it, refine it, study it. Wine, real mechanism in some concentrations, replace it with better antiseptics. Moldy bread, real mechanism in some molds under some conditions. Isolate the compound, purify it, dose it. Maggot, real mechanism. Sterilize the larvae, control the application, bring it back into clinical use. The modern surgical tradition did not throw all of it away. It took what had a mechanism and stripped away everything else. The incantations, the sympathetic materials chosen for their symbolism rather than their chemistry, the treatments whose only logic was analogy or tradition. What you're left with, looking back across the full length of that history, is something quieter than barbarism and something more complicated than wisdom. You are left with people standing over a body that was losing, a wound that was already warm, already pulling apart at the edges, already beginning the slow process of declaring defeat. And those people reaching for whatever the accumulated observation of their tradition told them might buy another day. Not because they understood penicillium, not because they had read Fleming, because they had watched enough people die to know that some things seemed to help and some things seemed to hasten the end, and they had written it down and passed it forward and pressed it into the wound with their own hands. That is not science, but it is the thing that science grew out of. Careful watching in desperate conditions, recorded honestly, handed to the next person who stands over the same kind of wound with the same kind of choice. The tools change. The motive underneath them never did.